This video is about pattern visual evoked potentials. I initially intended to make the talk about pattern visual evoked potentials in one go, but it became too long, so I broke it in two parts. This is the first part. The second part will be posted soon. This video is intended for the clinical neurophysiology fellows at Nicklaus Children's Hospital. The bulk of this talk will be conducted in a question and answer format, but I will first provide you with a brief introduction. This introduction will serve as the blueprint for most of the upcoming questions. Pattern visual evoked potentials are about P100. About P100 latency, P100 amplitude, and P100 internal and external morphology. But it is also about the factors that influence P100. Some of these factors are related to the individual, such as age, eye factors, gender, level of attention, but by far the most important of all factors influence P100 is the pattern used as a stimulus. Patterns used for the stimulus of visual evoked potentials include checks barred with sharp delineations, whose linear representation will look as sharp up and down incursions, and sinusoidal grating stimuli. They are called sinusoidal because if represented in a linear fashion, they have a smooth up and down configuration between blacks and clear color lines. Checks presented in the form of a checkerboard are by far the most widely used pattern for VEPs. Checkerboards influence P100 latency, amplitude, and morphology through additional factors. Not knowing these checkerboard related factors influence on P100 can be the difference between calling a normal study abnormal and an abnormal study normal. To avoid this situation, we need to know how these multiple checkerboard factors influence P100. These factors are distance from eye to board, reversal frequency, color, contrast, luminance, size of the board, check size, and mode of a stimulus presentation. Modes or methods of checkboard presentation include pattern reversal, where the check that are white or light color change to black and vice versa. This method is by far the most frequently used to obtain visual evoked potentials in clinical practice. Another mode of checkboard presentation is pattern onset and offset. This mode of checkerboard presentation consists of white and black checks turning gray and then turning white and black again in order to produce a stimulus. This mode of checkerboard presentation is probably the second most common method used in clinical practice. Another modality is steady state. This method is determined by the rate of reversal. All of the above modalities previously mentioned can, at least theoretically, be studied using different types of fields, which include full field, monoocular or binocular stimulation, half field stimulation, monoocular or binocular. Hemifield stimulation can be performed using the lower or the upper half of the checkerboard, or the right or the left side of the checkerboard. Another way that visual fields can be produced is by multifocal stimulation. At this point, I will start the question and answer section of this talk. The first question is, how far should the board be from the patient? A, 1 meter, B, 2 meters, C, 3 meters, D, 4 meters. This question obviously addresses the issue of distance from the board to the patient's eye. The recommended distance is 1 meter from the eye being tested to the board, but the distance can be adapted taking into account the size of the checks and the size of the checkerboard. Using 8 millimeter square checks at a distance of 1 meter, the image created in the retina corresponds to about 27 minutes of the arc. Using 8 millimeter square checks at a distance of 0.5 meter, that is of half a meter, the image created in the retina corresponds to about 55 minutes of the arc. Using 4 millimeter square checks at the distance of 0.5 meter, the image created in the retina corresponds to about 27 minutes of the arc. The measure of the size of the image created by one check of a checkboard on the retina is referred to as the visual angle. So the answer to this question is 1 meter. Next question. Ambient luminance should be maintained constant in the testing room. A true, B false. This question addresses luminance. Luminance refers to the amount of light produced by the board and the light present in the room where the exam is being conducted. The mean luminance of the board is calculated by measuring with a photometer the maximal and the minimal light output at the center and at the periphery of the board, adding them and dividing them by 2. The International Society for Clinical Electrophysiology of Vision recommends that the mean luminance of the board should be 50 candelas multiplied by -2. In Aminoff's book, the number given for the desirable mean luminance is at or above 100 candelas per meter squared. The room luminance should be low. In other words, the room should be dimly lit to minimize the effect of ambient light. And when the board is on, the room should at the most be 20 to 40% lighter or brighter than when the board is off. That is, before the testing of the board, the room should be darker. When the testing is taking place, it could be a little bit lighter, but not more than 40% than it was when the room was not being used for performing the test. Aminoff's book states that background luminance should be 30 to 50 candelas per meter square. Despite the different numbers given by different authors, as you just heard, all agree that the background luminance should be kept constant. So the answer to this question is A. Next question. Checkerboard visual evoked potential should be performed under a scotopic environment. A true, B false. The testing environment for pattern visual evoked potentials should be photopic, which relies on cone function. It should not be scotopic, that is vision in the dark, which relies on rod function. A statement in Luther's book mentions that it takes 30 minutes for photic vision to become scotopic vision. It does not mention how long it takes for scotopic vision to become photic vision. What I take of the previously mentioned statement is not to keep the patient waiting in a dark room before performing a visual evoked potential. I like to keep the patient in the same room before and during performing a visual evoked potential. So the answer to this question is B. Next question. Mean luminance affects P100 amplitude but not latency. A true, B false. Luminance should be kept constant during testing. That is, the total amount of light present in the testing room when the ambient light and the light generated by the checkerboard are added should not change while a subject is being tested, and it should be kept as it was when the controls to determine the normal values for the given lab were obtained. This is because more light decreases latency, less light increases latency. A P100 with a latency of 104 obtained during dim light testing may be delayed by 4 milliseconds if total luminance is increased. It has been estimated that an increase of the light in the room by a factor of 10 decreases the latency by 12 milliseconds. It has also been estimated that an increase of the light in a room increases P100 amplitude, and a decrease in the light present in the room during examination decreases the amplitude of P100. You can see in this cartoon a visual evoked potential obtained under dim light with an amplitude of 4 microvolts, and once the light is increased, the amplitude increases by 0.7 microvolts. So the answer to this question is false. Next question. Which of the following statements regarding contrast is not true? A should be kept between 50 and 80%. B, P100 amplitude increases with increasing contrast. C, no further increase in P100 amplitude occurs after contrast is more than 40%. D, it is measured using Candela's contrast values. Another factor that influences P100 is contrast. Contrast is measured using Michelson contrast values. Michelson contrast is determined by subtracting the minimal luminance from the maximal luminance of the white and black checks, dividing these results by the sum of the maximal luminance and minimal luminance, and multiplying the result of this division by 100. The desirable contrast is stated differently in several books. Lueders state that it should be equal or more than 40%. Aminoff states that it should be from 50 to 80%. The International Society of Ophthalmology suggests using more than 80% contrast. The Illustrated Manual for Clinical Evoked Potentials states a desirable contrast of 95 to 99%. And the primer states that bright and dark contrast should be more than 0.5. Lueder's book further states that no further increase in amplitude will occur after the contrast is 40%. This visual evoked potential was done with a mean contrast between white and black checks of 98%. This other one with a difference between white and black checks of 25%. P100 latency was 103 milliseconds when the test was performed using 98% contrast, whereas when the test was performed using 25% contrast, the P100 latency was 122. Amplitude with 98% contrast was 4.43 microvolts, and with 25% contrast, the amplitude was 3.30 microvolts. So the answer to this question is D. Next question. Central and paracentral retinal lesions may be more sensitive to red and black checks than to white and black checks. A, true. B, false. Another factor that influences P100 is color. Most checkerboard pattern reversal visual evoked potentials are done with white and black checks, but other colors such as red and black can be used, and they may provide information regarding the status of the paraphobia and phobia region more accurately and earlier than visual evoked potentials conducted with white and black checks. The reason for this is that the cones that are present in this area are more sensitive to red and black than to white and black checks. Thus, damage to the phobia and paraphobia region will probably be first detected using red and black checkerboards. So the answer to this question is true. Next question. Reversals per second and cycles per second is the same thing. A true, B false. Another factor that greatly influences P100 is reversal frequency. Reversal frequency can be given in cycle per second or in reversal per second. Cycle per second refers to the change of white to black and black to white. Reversal per second means the change from one color to the other, either white to black or black to white. One cycle per second implies 2 reversals per second. Looters recommend the best reversal per second frequency for pattern reversal VEP is from 0.5 to 4 reversals per second. Other, which I have signaled by changing the coloring of the letters to aqua, suggest 1 to 2 reversals per second. Some advise not to use hertz to describe reversal frequency to avoid confusion. Others, I think, wisely recommend not to use a reversal frequency integer of 60 to avoid 60 Hz electrical artifacts in the United States, or to avoid any integer of 50 in countries using 50 Hz current. Another important determining ingredient in the reversal frequency is the refreshment rate. That is the time it takes for all the checks in the board to change from one color to the other. In this frame, I am representing a visual evoked potential done using a cathode ray tube. Cathode ray tubes changes from one color to the other instantaneously. Notice that using this system, the latency to P100 is 109. Using a liquid crystal display with a 2 millisecond delay, the P100 latency in the same subject under the same conditions is 114 milliseconds. Using a similar platform with a refreshment rate of 8 milliseconds, the latency to P100 goes up to 118, and using a liquid crystal display with a 30 millisecond refreshment time, the latency is delayed to 158 milliseconds. The bottom line is to use liquid crystal display with a short refreshment rate, since cathode ray tubes are no longer in use in most places. It is interesting the comment made by Creel, which contradict the previous statements. I do not know the instrument he uses to arrive to these conclusions. So the answer to this question is false. Next question. Steady state checker reversal visual evoked potential pattern has clinical use. A true, B false. This question addresses the effect of reversal frequency on P100, but it also, following the scheme that I previously described in the introduction, addresses the effect of mode or method of a stimulus presentation upon P100. As I presented originally, because it determines if the potential will be called transient or steady state. The rate of reversal can produce single potentials, also referred to as transient, or it can also produce continuous activity, which is referred to as steady state. At the rate of 1 reversal per second, the P100 occurs as a single peak or wave that can clearly be differentiated from the background. The same occurs when the reversal frequency is of 2 reversals per second. In such a case, the potential will still be able to be identified as a single unit. By the time the reversal rate goes to 4 reversals per second, the wave looks more convoluted, but still a period of baseline stabilization can be appreciated. By the time the reversal rate goes up to 6 per second, there are no period of baseline stabilization, and the term steady state can be used. Further increase in reversal frequency to 8.3 reversals per second, to 10 reversals per second, to 12 reversals per second, and 16 reversals per second, in addition to blurring the baseline, produces a loss in amplitude. Most consider that steady state pattern reversal visual evoked potentials have no clinical use. Others, that is, fewer people, consider that it does have a place in the clinical evaluation of patients, but they add that is basically unreliable. So the answer to this question is A. Next question. The term critical frequency of phonic driving is used to refer to the highest rate at which a steady state can be distinguished using pattern reversal checkboard stimuli. A true, B false. This paper, looking at the critical frequency of phonic driving and multiple sclerosis, published in Archives of Neurology in 1980, coined in my mind the use of the term critical frequency of phonic driving. The critical frequency of phonic driving implies the highest rate at which an individual potential can be identified using flash stimuli at fast rates. Patients with multiple sclerosis often have a lower than normal critical frequency of phonic driving. The conclusion of this paper was that the critical frequency of phonic driving was somewhat more sensitive than pattern reversal visual evoked potentials to detect abnormal visual conduction in patients with multiple sclerosis. These frames shows driving responses to different rate of flash stimuli. The dots under the wave indicate the stimulus rate. Here, the stimuli were given at 20 per second, here at 76 per second, and here at 85 per second. You can see that at this rate, no longer can the individual potential be recognized, thus making 76 the critical frequency of phonic driving in this example. The normal critical frequency of phonic driving changes with age. From 20 to 30 years of age, it is 72. From 30 to 60 years of age, it is 68. And after 60 years of age, it is 60. This new frame is an example of an abnormal critical frequency of phonic driving. You can see that the phonic driving is normal at the level of the retina, as attested by the recognizable potentials in the electroretinogram. at the three presented frequencies, whereas at 42 flashes per second, no individual potential can be identified from the occipital recording. This indicates that 34 flashes per second was the critical frequency of phonic driving in this patient, implying that this is an abnormal study. And this is so because the electroretinogram responses are present at 42 flashes, and the critical frequency of cortical phonic driving is lost at 34. This finding indicates an abnormality in the optic nerve. So the answer to this question is false. Next question. The degree of neuronal activation by different visual stimulus modalities, such as contrast or orientation, changes at different levels of the visual system. A true, B false. I am including this sketch from the Annals of New York Academy of Science to emphasize that the degree of neuronal activation by a given modality of a stimulus changes at different visual system levels. At the level of the retina, the receptive field is monoocular. Diffuse light is a powerful stimulus. Position, resolution, and contrast are also significant stimuli, but contrast much less than the other two. At the level of the lateral geniculate ganglion, the receptive field is still strictly monoocular, but unlike as in the retina, diffuse light is a poor activator. Position and resolution continue being significant activators, but contrast become the most powerful activator at this level. It is not until cortical processing takes place, that is in the area 17, that binocular vision is achieved. At the cortical level, diffuse light is an ineffective stimulus, and orientation become the most powerful activator. Please stop the video at this point and take a few minutes to read this paragraph. Also notice how inexpensive it was to get a reprint back in 1982. So the answer to this question is A. Next question. Which of the following changes in P100 will occur when going from a 2 reversal per second to 4 reversals per second? A. Consistent increase in P100 amplitude. B. No consistent changes in P100 amplitude or latency. C. Consistent prolongation of P100 latency. D. None of the above. At a rate of 2 or 2.1 reversals per second, the occipital cortex produces easily identifiable waves. Latency to P100 is consistently increased at about 4 reversals per second. This is a cartoon representing a visual evoked potential collected at 2.1 reversals per second. At such a rate, P100 latency was 103 milliseconds. Changing the rate to 4.1 reversal per second, delayed P100 latency to 109 milliseconds. So the answer to this question is C. Next question. As long as the patient looks at the monitor, it does not matter if focusing on it or not. A true, B false. Among the factors influencing P100 is attention. This frame shows the visual evoked potential of a subject looking at the monitor and paying attention to it. P100 latency is 106 milliseconds and the amplitude is 5.86 microvolts. In this new frame, the subject is also looking at the monitor but not focusing on it. As you can see, the latency is delayed by 5 milliseconds and the amplitude is significantly less. So the answer to this question is false. Next question. Abnormal pattern reversal visual evoked potentials cannot be fake. A true, B false. A normal subject looking and focusing on the board has a normal visual evoked potential. The normal visual evoked potential corresponds in this frame to the solid lines. The same normal subject looking at the board but not focusing on it will produce an abnormal visual evoked potential. This is represented in this frame by the dashed lines. Notice that P100 differs at the OZ to CC derivations. This is a different normal subject. Notice the different color armbands fixating and concentrating on the board and producing a normal visual evoked potential. In this frame, he is meditating. Notice the abnormal visual evoked potential. As you can see, the pattern reversal visual evoked potential is almost completely flat. The fact that the patient was meditating was not noted by the tech during the test. So the answer to this question is B, false. Next question. Visual acuity should be corrected prior to checkboard reversal visual evoked potential. A true, B false. Among the general factors that influence P100 are I factors. I factors are the only one that are exclusively related to visual evoked potential among these general factors. One I factor, and a very important one, is visual acuity. This visual evoked potential was obtained with the subject having an uncorrected vision of 20/40. P100 latency was 109 milliseconds. Amplitude was 4.94 microvolts. When vision was corrected to 20/20, latency decreased to 106 milliseconds and amplitude became 4.40 microvolts. So the answer to this question is A, true. Next question. Pupils should be checked prior to performing a visual evoked potential. A true, B false. A second eye factor that influences P100 is asymmetrical pupils. The reason for this is that luminance greatly affects P100, as we previously discussed, and pupil diameter controls the perception of luminance by the eye being tested. Asymmetrical pupils can produce significant latency discrepancy between the mediatic eye and the normal eye. The latency may be reduced in the eye with a dilated pupil when compared with the non-dilated eye. The question about if the test should be postponed based on the use of mediatic is a moot one if the pupils are checked. If pupils are asymmetrical, or even if sluggish, that is, even if one of the pupils is sluggish because of the use of mediatics, do not conduct the test and wait for the effect of the mediatic drugs to go away. So the answer to this question is A. Next question. Checkerboard pattern reversal full field visual evoked potential are most often done bilaterally. A true, B false. I will go back to the checkerboard factor chart to specifically talk to you about the mode or method of stimulus presentation. As you can see in this list of mode of checkerboard presentation, which I introduced to you before, one of the possible ways to present the stimulus is by using a full field binocular stimulation. This diagram represents a visual evoked potential being conducted with the wave being recorded up to 250 milliseconds using a full field binocular stimulation. Electroretinogram is being recorded on the left, and you can see a normal P50, and another electroretinogram is being recorded on the right. You can also see a normal P50. Now I want to call your attention to the MO to MF derivation. You can see a P100 occurring at the mean, indicating normalcy. This test is hardly performed because it lacks localization value, except that in the presence of a normal ERG and an abnormal visual evoked potential, the possibility of a post-retinal visual pathology is supported. So the answer to this question is B, false. Next question. The vector produced by monoocular checkerboard full field reversal visual evoked potential points toward the side of the eye stimulated. A true, B false. P100 is, as I am sure you know, the only clinical significant peak in visual evoked potentials, that is, in pattern reversal visual evoked potentials. This peak is best captured using a mid-occipital to mid-anterior derivation. And as suggested by its name, it usually falls around 100 milliseconds after the stimulus. In this frame, I have introduced a representation of the visual pathways, with the left eye being occluded and the right eye being stimulated by the checkerboard. In the little corner to your right, I have added the color representation of a dipole, red being positive and blue being negative, which I will use in a few frames. The arrow I have just introduced indicates the site of the stimulus in the retina. Here, in this frame, the arrow points to the right eye, temporal, peripheral retina. The stimulus to activate the right eye temporal peripheral retina arises from the distal left side of the visual field presented to the right eye. Activation of the right eye temporal peripheral retina produces electrical activity that, after traveling through the visual pathways, arrives at the anterior-most region of the visual cortex in the right hemisphere, that is, to the primary visual cortex in the right hemisphere, and at that level produces an electrical field with a vector that is directed towards the opposite side. In this case, the direction of the vector is towards the left occipital parasietal region, which is to the same side that the visual field producing it. So remember, left visual field stimulation of the peripheral temporal retina of the right eye produces a vector pointing to the left occipital parasietal region. As you can see in this frame, I have retained the pathway and the vector produced by stimulation of the right eye peripheral temporal retina. Now, let's see what happens when the stimulation takes place in the peripheral nasal retina of the right eye, as it is indicated by the aqua arrow I have just introduced. In order to produce a stimulation of the peripheral nasal retina of the right eye, the stimulus has to arise from the right side of the board, that is, from the peripheral right side of the board. Activation of this segment of the retina produces left hemisphere most anterior visual cortex activation. This activation leads to a field with a vector pointing to the right parasietal occipital region. So the vector points to the same side as the stimulating segment of the visual field or the board. So remember, right visual field stimulation of the peripheral nasal retina of the right eye produces a vector pointing to the right parasietal occipital region. So why these vectors do not translate into strong parasietal occipital fields during monocular pattern reversal visual evoked potentials? The explanation seems to be because most of the power of the fields contributing to P100 arises from the central retina. It has been estimated that 80% of the power of the field that arises to produce sagittal P100 arises from the 8th degree of the central retina. And because some suggest that colliding electrical fields lose power. So, as the story goes, the colliding weak vectors representing electrical fields created by peripheral retina stimulation going in the opposite direction as they collide and partially cancel each other out. So remember, peripheral retina stimulation of the right eye produces vectors that cancel each other out. I will now consider what happens as a consequence of a stimulation of the central retina, which, as you recall, is by far the main contributor to the P100 when P100 arises as it normally does in the sagittal occipital region. Stimulation of the temporal central retina of the right eye, which is provoked by the central area of the left visual field stimulating the right eye, excites the visual pathways leading to activation of the right occipital pole, that is the posterior most region of the primary visual cortex. Activation in this region produces a field with a vector going directly backwards. Stimulation of the nasal central retina region of the right eye arising from the central right side of the visual field, in this case of the checkerboard, activates the visual pathway in such a way that the left occipital pole becomes activated. Activation of the left occipital pole produces a vector which goes directly backwards. These vectors, that is the vector from the right and left occipital pole, add, since they are going in the same direction, and they create a large mid-occipital vector, which in this case, that is in the case of P100, it is positive. So the answer to this question is false. Next question. In the presence of a left complete optic radiation lesion, the vector of the field created by a right monoocular checkboard full field reversal visual evoked potential will point towards the side of the eye being stimulated. A true, B false. Normal right monoocular checkboard full field reversal visual evoked potential vector points directly backwards, as we have previously explained. An abnormal right monoocular checkboard full field reversal visual evoked potential due to a lesion in the left optic radiations is the consequence of the absence of left visual cortex activation, and thus the absence of production of an electrical field in that region. The absence of an electrical field due to failure of left primary occipital cortex stimulations allows the normally suppressed vector from the right anterior most visual cortex to expand and influence the overall field created by activation of the right visual primary cortex, thus producing a field with a vector towards the left occipital region, as indicated by the arrow. So the answer to this question is false. Next question. In the presence of a left complete optic tract lesion, the vector of the field created by a right monoocular checkerboard full field reversal visual evoked potential will point towards the side of the eye not being stimulated. A true, B false. Normal right monoocular checkerboard full field reversal visual evoked potential vector points directly backwards, as we have seen 2 or 3 times now. Now let's consider what happens when there is a lesion in the left optic tract, as it is shown in this frame. An abnormal right monoocular checkerboard full field reversal visual evoked potential due to a lesion in the left optic tract changes the direction of the vector due to the absence of a left visual cortex activation. The absence of left visual cortex activation allows the normally suppressed vector from the right anterior visual cortex to expand and summate with the vector from the right occipital pole, thus producing a combined vector that points to the left occipital region. Notice that the derivation used to indicate the maximal power of P100 in this frame is O1 to ZZ. Next question. In the presence of a chiasmatic lesion, the vector of the field created by a right monoocular checkerboard full field reversal visual evoked potential will point towards the same side as it does in the presence of a left optic radiation lesion. A true, B false. In the presence of a left optic radiation lesion, a right eye full field pattern reversal visual evoked potential produces a field with a vector pointing to the left occipital region. That occurs because of the absence of left occipital cortical activation. In the presence of a chiasmatic lesion, a right eye full field pattern reversal visual evoked potential produces a field with a vector pointing to the left occipital region because of the absence of left occipital cortical activation. So the answer to this question is A. Next question. In the presence of a right complete optic radiation lesion, the vector of the field created by a right monoocular checkerboard full field reversal visual evoked potential will point toward the side of the eye being stimulated. A true, B false. A normal right monoocular checkerboard full field reversal visual evoked potential vector points directly backwards, as we have said now quite a few times. A right monoocular checkerboard full field reversal visual evoked potential vector in the presence of a complete right optic radiation lesion does not points directly backwards. The lack of right primary visual cortex activation has a consequence. The consequence is that the field from the anterior most region of the left visual cortex, now unimpeded by the corresponding opposite field, enlarges and contributes to the ultimate field, thus displacing the vector of the field towards the eye being stimulated. In this case, towards the parietal region located at O2. So the answer to this question is A. Next question. What is the direction of the vector produced by right eye full field monocular stimulation using 30-minute checks and 8-degree boards? A. Mid-occipital. B. Ipsilateral occipital. C. Contralateral occipital. D. None of the above. The size of the checks and the size of the board used for stimulation contributes to the region of the retina preferentially stimulated. Using a check board of 8 degrees with 30-minute checks, the vector points to the mid-occipital region by the mechanism described while answering the previous question. So the answer to this question is A. Next question. The size of the checks and checkerboard does not make a significant difference in monoocular checkerboard full field reversal visual evoked potential vector direction. A. True. B. False. This figure represents right eye checkerboard full field reversal stimulation. Using medium checks and medium fields, that is using checks from 24 to 32 minutes with boards of 6 to 12 degrees, the vector of the field created is maximal in the mid-occipital region. Using small checks and small fields, that is checks of 12 to 16 minutes and fields of 2 to 4 degrees, the field created has a vector also pointing to the mid-occipital region. The use of larger board with larger checks, that is checks of 40 to 50 minutes and boards of 16 to 32 degrees, also produces field with the vector pointing to the mid-occipital region. So the answer to this question is true. Next question. The area of the retina stimulated while doing monoocular checkerboard full field reversal visual evoked potential is not influenced by the size of the checks and the checkerboard. A. True. B. False. Check sizes and board sizes go together most of the time. So a small check size and a small board preferentially stimulate the fovea. Medium checks with medium board preferentially stimulate the fovea and the parafoveal region. And large checks and large board preferentially stimulate the perifovea and the neighboring retina. So the answer to this question is false. Next question. The area of primary visual cortex activated while doing monoocular checkerboard full field reversal visual evoked potential is not influenced by the size of the checks and the checkboards. A true, B false. Monoocular full field stimulation using medium-sized check and boards preferentially activates the mid-region of the primary visual cortex. Monoocular full field stimulation using a small size check and board preferentially activates the tip of the occipital pole. Monoocular full field stimulation using large size checks and board preferentially activates the anterior region of the primary visual cortex, as shown by the arrows. So the answer to this question is false. Next question. P100 latency and amplitude in subjects with 20/20 vision is not influenced by the size of the checks and the checkerboard used. A true, B false. P100 latency is shortest and the amplitude is highest when the smallest check size that can be seen are used. In usual testing condition, P100 latency is shortest and the amplitude is highest when using small size checks and boards. This can be rationalized by thinking that the small checks preferentially activate the occipital pole, which are closer to the electrodes. Generally, using medium-sized checks and boards produce a slight latency delay and an amplitude slightly smaller than when using small checks and boards. This can be rationalized again by thinking that it is the medium area of the primary cortex, the one that gets activated when we use medium checks. Generally, when using large checks and large board, P100 occurs even a little bit later, and the amplitude is even a little bit smaller. This can again be rationalized by thinking that large checks preferentially activate the anterior-most region of the primary visual cortex. Thus, it is the region of the visual cortex that is furthest from the occipital electrodes. So the answer to this question is false. Next question. In normal subjects with 20/20 vision, monoocular checkboard full field reversal visual evoked potentials P100 latency and amplitude remains in the normal range despite using different checks and board sizes. A true, B false. This frame presents three visual evoked potentials obtained with three different check size and board sizes. As you can see, P100 latency falls within the normal range in all three, and P100 amplitude also falls in the normal range. So the answer to this question is A. Next question. In subjects with 20/80 vision, P100 latency is usually shorter and amplitude is usually bigger when tested with large checks and board than when tested with small checks and boards. A true, B false. A subject with good vision would see small checks with good definition. A subject with poor vision would see small check with poor definition, as presented in this frame, leading to a P100 that is late and small when using this size check and board. In the same subject, that is, in a subject with poor vision, the larger checks would allow better definition of the edges, thus producing a P100 with shorter latency and bigger amplitude. So the answer to this question is true, A. Next question. Please take a look at this frame and decide whether the visual evoked potential shown in it are normal or abnormal. The panel on your left was obtained with 30-minute checks. The mid-occipital to mid-frontal derivation shows a P100 with a latency of 95 milliseconds. Using 60 minutes checks for stimulation, the latency was 96 milliseconds. So remember, small checks and a small board stimulate the fovea, and in a person with normal vision, that is with normal visual acuity, generally produce the earliest and biggest P100. Large checks and large boards in a person with a 20/20 vision stimulate preferentially the perifovea and neighboring retina, thus generally producing the most delayed and the smallest P100. Middle checks and board generally produces P100 latency and amplitude that are in the middle range. So the answer to this question is A, normal. Next question. Which of the following check size is recommended by the Academy for Clinical Neurophysiology for initial testing? A, 15 minutes, B, 30 minutes, C, 60 minutes, D, 120 minutes. Of the three sizes of checks and board that we have been discussing, the Academy of Clinical Neurophysiology recommends using middle checks and board for regular testing. So the answer to this question is B. Next question. The relation between check size and board checker size and P100 latency and amplitude is linear. A, true, B, false. This frame and those that will follow match check size with visual evoked potential waves. The green arrow indicates P100 amplitude and the aqua line indicates the latency of P100. In this instance, 2-degree checks, which equates to 120-minute checks, are being used. Notice the amplitude and latency when this check size is used. Here, the check size is 60 minutes. Please notice that the amplitude is less, but the latency remains unchanged. Here the checks are 30 minutes and the amplitude is even less, but the latency remains unchanged. Here, using 15-minute checks, the amplitude is about the same as it was when we use 30-minute checks, and again the amplitude remains unchanged. Here the check size are 7 minutes. Notice that there has been a change in morphology of the wave, and also notice that the latency to P100 is delayed. The frames I have just shown you contradict the neat and orderly explanation about check sizes and board that I have previously given to you. But remember that throughout the discussion I used the word generally. I did so for a reason. The reason is what I will try to show you in this frame, which is that there is some disagreement as to what the implications are of decreasing the check size in different textbooks. This difference may arise from the fact that decreasing from 30 minutes to 15 minutes check size is not the same as decreasing it from 15 minutes to 7 minutes check size. Be it as it may, I will show you in this frame the explanations or the numbers given by different textbooks. In clinical neurophysiology, it is stated that decreasing check size to 10 minutes increases latency and amplitude. In the Essentials of Clinical Neurophysiology, it is stated that decreasing check size to less than 15 minutes increases latency and decreases amplitude. In Chiappa's book, multiple articles are quoted, and they have conflicting results. The best that I could summarize it is that decreasing check size below a certain degree increases latency. That decreasing the size of the checks that stimulates the central retina increases P100 amplitude, and that decreasing the size of the checks that stimulate the peripheral retina reduces P100 amplitude. In the Illustrated Manual of Clinical Evoked Potential, in page 37, it is stated that in general, smaller check sizes produces visual evoked potential of shorter latency. Adding later in the discussion that stimulation of the peripheral retina, which is produced by larger check sizes, contributes to the amplitude of P100. I interpreted this statement to imply that the less of the peripheral retina that is stimulated, the smaller the amplitude of P100. Aminoff Books concludes that there is a complex relation between check size and P100 latency and amplitude. So two things appear to be certain regarding check size and P100. Using checks of more than 2 degrees or 120 minutes produces an increasing luminance that tends to produce flash visual evoked potential rather than pattern visual evoked potentials. Notice that the P100 using 2 degree checks is biphasic and distorted, and I am sure that they look even worse when using more than 2 degrees. That is, when using checks of more than 2 degrees. The other conclusion about check size is that if the checks are smaller than visible, that is, if the edges of the square cannot be seen or are blurry, P100 latency increases and the morphology changes. So the answer to this question is false. Next question. Which of the following checkerboard will produce larger amplitude pattern reversal visual evoked potentials, A or B. Checkerboards with small checks in the central area and larger checks in the peripheral area produce P100 with higher amplitude than those produced by using checkerboard with medium size, small size, or large size checks by themselves. So the answer to this question is B. The last frame I like to leave you with is this one. Some things are just difficult to understand, but if we attempt to make them easier, then they become not true. Thank you.